I hope you don't have any conflict of interest in sharing this video in YouTube and Facebook sharing.
I do not.
Thank you so much. Good evening and good morning, friends. Welcome you all to this IPL series called as Interact with a Pioneer and Learn. I think we have one good pioneer to talk on this very interesting and important topic. When you have nothing, little is lot. I think most of the patients who have spinal cord injuries are distressed, and of course they're depressed and they don't have a life when they have a spinal cord injury. When we think of the topic, I think the apt surgeon person is Dr. Scott, who is a vital and integral part of this pediatric upper limb injuries and other congenital brachial plexus palsies. I think he is the chief of the staff for the Shriners Hospital for Children in Philadelphia. He has done quite a lot of amazing work and he has pioneered many, techniques and written more than many hundred articles in the field of pediatric upper limb fractures. I should thank Dr. Paco for bringing Dr. Scott to this program. I think he's the one who really helped me to get Dr. Scott here. And Paco, I think we're all deeply indebted to your wonderful service and fantastic idea you are doing in Palm Talks. I think that was amazing. He was just discussing with Dr. Scott. That should be a game changer or a paradigm shift in terms of getting protocols for management of upper limb fracture. I think that's one thing which I'm looking forward to get to see those protocol published. With this brief introduction, I think Paco is also in a good environment. He'll be joining with us program, and then I requested Dr. Scott to start this evening program. It's called as IPL, the Interaction with the Pioneer and Learn series. Thank you so much, Dr. Scott, for accepting, and please go ahead.
Thank you, everyone, for joining this talk. And I know everyone's busy, so we'll try and make it concise and to the point. And I just hope that Paco doesn't take a swim during the middle of my talk. But I am going to talk on something that's near and dear to my heart. So for most of my career, I've taken care of persons with spinal cord injury, mainly children. And we've really progressed in our management of these patients that really need upper extremity surgery. So the title, as Terrence said, is When You Have Nothing, A Little Is a Lot, which was coined by Sterling Bonnell. And I'm going to talk about nerve and tendon transfers in this particular population. When you have a spinal cord injury like Jared here, riding his horse in a rodeo, and suddenly his life has changed forever, becoming an able-bodied person to an impaired person is incredible change. So we see these kids acutely, and we see them over the years, and we see them adjust both physically and emotionally, but it is a devastating injury. But if you can give them some upper extremity function, you can truly improve their life and make them more independent. This is a picture of Sterling Bonnell on the left, who I said previously coined this term. And here are persons with spinal cord injury. And if you ask people with spinal cord injury what they want, do they want to walk? Do they want to take care of themselves in terms of bladder or bowel? Do they want to have arm function? Arm function's way up there. Arm function's above actually walking because they want to be independent. So bladder, bowel, and arm function are what they really want to do. They want to be independent in the bathroom, and they want to take care of themselves in terms of feeding and eating and all those important things that we do every single day. I do have to spend a second just talking about nerve principles. And if you're not familiar with spinal cord injury, you need to understand that where the spinal cord injury occurred, where the cord was disrupted, that is a lower motor neuron injury because it's affected the anterior horn cells. Now, obviously, above that level, everything's normal. There's no injury whatsoever. But below that injury, it's an upper motor neuron injury, meaning the cord is just disconnected, meaning the anterior horn cells are alive and the children are spastic below the level of injury or the zone of injury. And we can consider nerve transfers late if the recipient nerve is below the level of injury. And we'll talk about that in a bit. If you look at complete spinal cord injury, which is different than incomplete spinal cord injury, complete injury typically recovers one root. So when the child is injured, whatever level they are, they typically recover one root. And that's it. They don't recover anymore. Now remember, like I said, the lower motor neuron, the level of the injury, will lead to end plate demise by somewhere between 18 and 24 months. But if the lower motor is intact, like below the level, the muscle is spastic and alive forever, allowing an opportunity for late nerve transfer. Now, with reference to surgical techniques, we're going to kind of compare and contrast nerve transfers and tendon transfers because they're very, very similar. So the prerequisites are identical. The donor tendon or the donor nerve has to be available and expendable, and it has to restore function without losing function, meaning it has to be expendable. What we've learned over the last 2 decades is nerve transfers can be done in proximal nerves that have redundant axons. And when I started my career, we never thought we could take a piece of the ulnar nerve, a piece of the radial nerve, a piece of the median nerve high up in the arm and not lose any function. But as the nerves progress more distal, they lose some of this redundancy. But again, Jamie Bertelli and others have shown us that distal nerve branches may be expendable, and we'll highlight which distal nerve branches we use for nerve transfers in persons with spinal cord injury. Some important facts about muscles. The muscles need their nerve supply. Muscles are unhappy without their nerve supply, and they literally scream for help. And if you perform an EMG on a muscle that's lost its axons, after about 3 weeks or so, you see fibrillation potentials. We explain that to our residents and fellows like the muscle is screaming for help. And then unfortunately, without a nerve supply after 18 to 24 months, the muscle just shuts down. It will never recover. And if you look at it clinically, what happens is a normal muscle is red and beefy. A muscle that's having trouble becomes more pale, and then it becomes fibrotic when the nerve endplates have shut down. So the important thing, whether you're a spinal cord injury or peripheral nerve injury, timely evaluation and timely surgical is critical, especially for the areas affected by the lower motor neuron. Now, axonal regeneration remains slow. Despite some advances in nerve regeneration, it's still only 1 to 3 millimeters a day or an inch a month. And remember the term axonomy. Injured neurons without target connections is just bad. Again, back to the principle that muscles need their nerve supply. But there are some new distal nerves that may be expendable, mainly the supinator nerve we're going to highlight today. So supination is an extremely important function, but if you have your supinator and you have your biceps to supinate, then the supinator nerves become expendable. We also will occasionally use the distal spinal accessory nerve and the long thoracic nerve. But again, remember the principle that the function must be preserved by other functioning nerves and or muscles. The standard classification for spinal cord injury is the Asia classification, which is based on the lowest functioning cord segment. But a bunch of smart hand surgeons realized that this was not the best way to communicate. Meaning, if I said the child was an Asia cervical level 6, that may not mean the same thing to me as it means to Paco. So the upper extremity surgeons got together and came up with what's called the International Classification for Surgery of the Hand in Tetraplegia. Has to be the longest acronym ever made. My partner, Dan Zlotlo, just refers to it affectionately as the I-shit classification. But it's extremely important. And what it does is it grades the muscle based upon their segmental innervation from 0 to 9. So if you look at this classification, it has to be a grade 4 to get a grade. So if you're a grade 2, for example, you have weak wrist extension. If you're a grade 3, you have strong wrist extension. Most patients with spinal cord injury are what we're going to call a C5, C6 injury, meaning wrist extension is present, either a little bit weak or really, really strong. In general, the extensor carpi radialis longus is a very, very strong C6 muscle, and the extensor carpi radialis brevis brings in some of C7 muscle, as does the pronator. So if you just run through this list, it's so classic. Flexor carpi radialis is a C7 muscle. Finger extension at the MCP joint is a C8 muscle, or it can be C7 too, and then thumb extension C7. So the basic reconstruction ladder for spinal cord injury is just like we do for many, many different problems. Wrist extension is by far and away the most important task we perform in our wrist and hand. Wrist extension allows passive tenodesis, both for grip and for lateral pinch. The second most important task is pinch, primarily lateral pinch. Lateral pinch allows multiple daily functions, such as picking up a CD or picking up a key or grabbing this forceps like you see in the picture. The next most important, third rung on the ladder, is grasp. It allows us to hold onto objects, followed by digital extension. Now you may ask, why is digital extension fourth on the ladder? It's because most of us, when we drop our wrist into flexion, the fingers can open, which allows us to release objects. And digital extension is very difficult because MCP joint extension is C7 and IP extension is C8 and T1, or an intrinsic function. And then the holy grail is intrinsic function, which allows fine motor. All of us want to have fine motor. Reconstructing fine motor by surgery is incredibly challenging and incredibly difficult. So for years and years, tendon transfers were the gold standard. And icons like Moberg, Jim House, and Zancoli taught us how to do tendon transfers for person with spinal cord injury. This is Zancoli's grandson in the middle. We were together with Pablo in Mexico. And this was always what we did up until about, 10 or 15 years ago. And the standard treatment paradigm was as you see here. If they didn't have wrist extension and they had a brachioradialis, we transferred the brachioradialis to the extensor carpioradialis brevis. If they didn't have lateral pinch, but they had wrist extension, we transferred the brachioradialis to the flexor pollicis longus. If they had wrist extension, that was strong, we took one of the wrist extensors and transferred to the flexor digitorum profundus, and so forth and so on. But what happened? These luminaries came around and showed us that we could do other stuff and have other different operations for persons with spinal cord injury. So Chris Oberlin's on the left, Susan McKinnon's in the middle, and then Jamie Bertelli from Brazil is on the right. And they really changed the game, and they changed our approach to persons with spinal cord injury. Now, the basic comparison of nerve versus tendon is seen in this chart. I think that in general, with reference to strength, tendon transfers are better. With reference to dexterity and control, nerve transfers are better. With reference to success rate, tendon's a little bit more reliable. With reference to technical difficulty, nerve's a little bit more difficult. With reference to rehab, it's much more demanding with tendon because you have to protect your tendon repair, and much easier with nerve. And then timing with nerve transfer is critical, especially at the lower motor neuron level, and needs to be performed 6 to 12 months after injury. Tendon transfers can be done late, but nerve transfers can be done late in an upper motor neuron or well below the level of injury. So we're going to talk about a C5, C6 injury, and this is Jacob. I want to make sure that we are talking about the same thing. So C5, C6, you see very strong shoulder, including deltoid, right? And then C5, C6 is going to have intact elbow flexion, as you see here with Jacob. Nice and strong, full supination. Here I'm palpating the brachioradialis and the supinator, which are working. So rotator cuff is working, deltoid is working, biceps is working, supinator is working, elbow extension is not working. See, it's a C7, mainly a C7 function, and there's the strong brachioradialis. With reference to wrist extension, in Jacob's case, pretty darn strong. So it looks like he has 2 wrist extensors. If you can break wrist extension, meaning forcefully push it into flexion, they typically only have 1 wrist flexor. And then further examination of Jacob shows he has no finger flexion and he has no thumb flexion. So what is he by the International Classification for Surgery on Tetraplegia? Below the elbow, he has a brachioradialis and wrist extensors, and that's all he has. And this is showing that the EDC is spastic. This is a simple tapping on the muscle yields spasticity, meaning this is an upper motor neuron injury where the EDC is spastic. So how can we help Jacob? I think it really takes a village to raise a child and to help Jacob. I work with 8 occupational therapists, as you see most of them here, and this is a different child from Canada that we operate on. This is not Jacob. But let's go through this reconstructive ladder with reference to Jacob or any other child with a C5, C6 injury. So we follow the reconstructive ladder, although the elbow is not included in the ladder, but elbow extension is critical for persons with spinal cord injury. Elbow extension allows them to perform weight shifts, allows them to transfer, and allows them to push a manual chair up a hill and pop wheelies. And then we're going to talk about hand function. So with reference to the elbow, we need to restore elbow extension in a C5, C6 person with spinal cord injury. We can do it one of 2 ways, tendon transfer or nerve transfer. Our preferred tendon transfer is a biceps or triceps, which I'll show you, and our preferred nerve transfer is taking the posterior deltoid branch, leaving the anterior branch alone, and transferring it to one ahead of the triceps. For biceps or triceps, we harvest the biceps off of the radial tuberosity. We pass the biceps medially under the ulnar nerve. We no longer go over the ulnar nerve. That's a mistake we may have made in the past. And then we weave it through the triceps, and we attach it directly into the olecranon. So this sets our tension, radial tuberosity to the olecranon. And we fix it through transosseous tunnels. Here's an example. This is my partner, Dr. Z. This is an elbow extension, pretty darn strong against gravity, allows him to push the chair. He underwent bilateral biceps to triceps. He did actually rupture the one on the right. We had to revise it during the rehab process, but it's still pretty darn strong. That's the typical outcome you'll see. With reference to nerve transfer, again, we're going to transfer the posterior branch of the axillary nerve to the triceps. So this is us locating a triceps branch. This is the radial nerve proper, as you'll see here. And as we said, this is often an upper motor neuron injury, so it's still spastic, and you can stimulate it using a stimulator. Now we find the axillary nerve, which has 3 different branches, one to the teres, a posterior branch, and an anterior branch. We're going to take the posterior branch to the axillary nerve, and we're going to transfer it directly to one head of the triceps. This is a normal nerve, so it stimulates at a very low threshold in terms of milliamps, and here's your nerve transfer. It's fairly straightforward operation. In our hands, it has not gained the strength that we'd have achieved with a tendon transfer. So let's move down the ladder. So that's elbow. We need elbow extension. We have to give these persons elbow extension. If we move down the ladder in a C5, C6 injured patient, wrist extension is already present, so we don't need wrist extension. Then we're going to move down to pinch. So we're going to try and restore pinch one of 2 ways. The brachioradialis is a C5, C6 muscle which is present, which is primarily an elbow flexor. We can transfer that to the flexor pollicis longus, or we can do a nerve operation, transferring the supinator branches, which is a C5, C6 innervated structure, to the anterosseous nerve to yield lateral pinch. Here's an example of the tendon transfer. The brachioradialis must be harvested all the way up in the forearm to take advantage of its long excursion. If you release it just from the radial styloid, you don't take advantage of this excursion. This is the way you need to do this operation. It's then woven directly into the flexor pollicis longus, as you see here, and it provides lateral pinch. Again, pretty straightforward operation and straightforward tendon transfer. For the supinator, we're going to isolate the supinator nerves and transfer it to the anterosseous nerve, again using a stimulator. So what you see here is an isolation of the anterosseous nerve. And you're going to see, we're going to switch sides. This is me and Dr. Z. There's your supinator nerves. There's typically 2 supinator nerves that can be harvested, and they can both be transferred to the anterosseous nerve. Remember, you have to have a biceps because a biceps is your supinator, and supination is important for eating. That's your posterior osseous nerve being stimulated, and then we're going to transfer 2 of the supinator nerves directly into the anterosseous nerve. And there's our coaptations. Moving down the ladder, we need to talk about grasp. So again, a C5, C6 patient is going to have wrist extension. We've given them pinch. If they have 2 wrist extensors, we can give them grasp. This is lateral pinch being demonstrated. For grasp, we can transfer the extensor carpi radialis longus to the flexor digitorum profundus as long as they have an extensor carpi radialis brevis, because we don't want to lose wrist extension. And for nerve transfer, we can also do the same transfer we just talked about, the supinator branch to the anterior osseous nerve. Here's an example of the tendon transfer, the extensor carpi radialis longus to the flexor digitorum profundus. This is a very easy tendon transfer to perform. It's extremely synergistic, meaning that most of us, when we make a fist, extend our wrist, so it's easy for the patient to learn. If you do this tendon transfer on post-op day number 1, you can start them moving, and on post-op day number 1, they'll be able to flex their fingers because of the synergy between this tendon transfer. Here's a coaptation site. And here's an example of a supinator to the AIN. So this is grasp, supination, nerves to the anterior osseous nerve. So what I showed in the video before, this is a follow-up of Maddie showing that she can grasp from the from the nerve transfer. Moving down the ladder, so we've restored wrist extension because they have it. We've given them lateral pinch by nerve or tendon, and we've given them grasp by nerve or tendon. Now moving down the ladder is digital extension. This gets hard. You can, if you have availability, transfer the brachioradialis to the EDC, or you can transfer the supinator branches to the posterior osseous nerve. But you need to satiate wrist extension, lateral pinch, and grasp before you move into digital extension. The problem with digital extension is mainly it's an MCP joint or metacarpal phalangeal joint extension, because that's what the extrinsics do. Intrinsic extension is very difficult to obtain unless you do something to block the MCP joint from moving into hyperextension. On occasion, especially in a C7 nerve, a C7 injured patient, we'll transfer the supinator branch to the posterior osseous nerve. Now, this is always hard for the resident and fellows to understand because you're transferring a radial nerve to a radial nerve. But remember, the supinator branch is 5-6. The posterior osseous nerve is mainly C7, which is distal to the injury. This is an incredibly easy operation because they're right next to each other. You want to isolate the supinator branches. You want to make sure you don't have the radial sensory nerve, donor distal, recipient proximal, and then you want to just transfer them to each other. And then moving down the ladder, intrinsic function is really the holy grail. And whether you have an ulnar nerve palsy or you're a person with spinal cord injury or you're spastic, we don't have a good way to restore intrinsic function in persons with spinal cord injury. As you know, some people have done anterior osseous nerve to the deep branch of the motor nerve, but that's not available in these kids because the anterior osseous nerve tends to be a C8 and T1 nerve innervated structure, as is the ulnar nerve. And then intrinsic transfer, these are okay, but often in persons with spinal cord injury, there's just nothing left and nothing left. So intrinsic function is really out of the ballpark for persons with the C5, C6 spinal cord injury. Rehab, it's very protocol driven. We have all these rehab protocols for these persons with spinal cord injury following tendon and nerve transfer. In tendon transfer, there's an immobilization phase followed by a mobilization phase. Whether we move early or not depends on the patient and the size and integrity of our repair. And then we introduce strengthening and resistive exercises. We have very, very talented therapists, and you must have talented therapists to rehab these patients, and we rely and entrust our talented therapists. This is Sarah, one of our supreme therapists. For nerve transfer, it's different. You just got to be patient. And like this dog, you just got to wait and wait and wait. And then once you have reinnervation, then your reinnervation requires a skilled therapist, and then you need to retrain. In terms of outcome, there's a variety of different measures to look at. The big thing is obviously patient-reported outcome. The Canadian Occupational Performance Measure, if you're not familiar with this measurement, it's exceptional. It looks at patients pre and post-operative. They grade what they do and how they want to do it, and it's a great scale. And you can see just by this short little video, his COPM scores have been improved remarkably. He underwent biceps and triceps, right, to restore elbow extension, along with active pinch and active grasp tendon transfers. I think we do need to spend more time looking at independence and spontaneity, but these are different scales. There are the legacy measures, and this is Mary, who underwent biceps or triceps. She's as interested in legacy measures as we are. I think I find them mundane and they're not appropriate anymore. But range of motion and strength we clearly look at. It's just that what the patient perceives is better than our range of motion and strength measurements. And in terms of when you have nothing, a little, a lot, this is George, who was injured in a diving accident. We again did bilateral biceps to triceps tendon, and then we did distal pinch and grasp. And this is Cheryl, our therapist, on the right. And you can see nice, strong elbow extension. But again, this is kind of legacy measures, strength and range of motion. But if you look at George just in this short little video, this is him back home trying to push a wheelchair without any triceps. He can push on a smooth floor, but he clearly can't push up a hill. And this is George after biceps to triceps transfer. He's he's at the shrine. He just went home. And you can see the way he pushes and you can see the way he spins. It's just a whole different ball game than how he was. Some of it, obviously, he has a newfangled chair that's lightweight, but it seems to make a big difference. And with that, I will end my 20 minutes, and I thank you for your time. I'm available for any questions. This is George at our Rocky statue in Philadelphia. Thanks, Terrence. Thanks very, very much. Do I have to do anything, Terrence? Or just be quiet?
Thank you so much, Dr. Scott. Thank you so much for this wonderful and incredible talk on this subject. Very quite often less seen by most of our surgeons here. I think that's one important aspect we know, because I've been into the practice for so long years, and then I found very difficult to convince one patient to get into surgery. Uh, they come in a wheelchair, and so much amount of you explain them to nerve transfers and tendon transfer. I think it's very difficult in my hands to convince them to get into the surgical field. I think the amazing result in your series and the step ladder pattern of approaching how to and when to, it's really amazing and an eye opener for all of us. Thank you so much for this incredible talk. And we have a panelist, Dr. Takehiko from Japan, and Paco from Spain. I think they must be having a lot of queries, and any questions on this topic will be welcome.
Terrence, can I just interject this a moment? So even though we do all these nerve and tendon transfers, it's been shown by Kevin Chung and others that in the United States we have all these innovative surgeries that clearly make a difference. It's still the minority of persons with spinal cord injury that get treated by a surgeon, which is a shame. You know, the physiatrists are reluctant to send the kids to us for treatment, which is really not fair to them, because there's many more patients that are candidates for nerve or tendon transfer surgery, which will increase their independence and increase their spontaneity, than actually undergo surgery. So some of it is educating the physiatrist. And we've had this discussion over and over again, especially when it comes to nerve transfers, because there's really no downside. You're not taking away any of their function. And if you talk to Jamie Bertelli, that's where he came up with the concept of these nerve transfers in person with spinal cord injury, because they don't have good rehab in Brazil, and they don't need much rehab after nerve transfers. So I concur. We need to do a better job at educating our physiatrists and our referral patterns that these opportunities are available for persons with spinal cord injury.
Thank you so much, Scott. I mean, you rightly mentioned about that, because I get a lot of referrals from the neurosurgeons. Most of the patients, they land up in the neurosurgeons, and then it's very difficult for them or for us to get the patients from the neurosurgeon, thinking that all those cervical cord injuries are related to neurosurgery. There are other specialties which are really working on that, and think mass communication and education is a vital tool to spread this message that something is better than nothing in, especially in spinal cord injuries. I think that's a great opportunity. We have Jamie Betley also here. Probably if he can join us, he can throw us light on this topic. Else we have some, we can take some questions and any clarifications on this topic.
Okay. So can I make a question, Scott?
Yes, sure.
See, when you have a weak wrist extension, what is your strategy to treat that patient? So you can break the wrist extension. So what is your strategy?
So in persons that we can break the wrist extension, right, we cannot utilize, obviously, the second wrist extensor. So if they have weak wrist extension, the only thing that is available for them is a brachioradialis and maybe supinator nerves. So if you go back to the reconstructive ladder, if they have wrist extension, they don't need wrist extension, but they need lateral pinch. And lateral pinch can be given to them from a brachioradialis to the flexor pollicis longus, or if the supinator nerve is stimulatable, it can be given to them from a supinator to anterior osseous nerve transfer. But Paco, you're exactly right. You cannot harvest a wrist extensor in anybody with weak wrist extension. That would hurt that person because you take away the highest rung on the ladder.
So basically, you go to the old strategy, tendon transfers.
Most of the time, I'll go to
except for the supinator to the posterior interosseous nerve.
That's correct. And what Jamie will say, if they have wrist extension, they likely have a supinator nerve that's working.
Mm-hmm. Okay. Scott, you had you did a lot of patients. In a lot of patients, you did elbow extension reconstruction with biceps to triceps. Have you compared tendon transfer with nerve transfers for triceps reanimation?
Yeah. So it's a great question. So we have, it's a really good question. We've done a bunch of nerve transfers for elbow extension. We can't seem to get the powerful result that Jamie gets from elbow extension. We haven't compared and contrast, but I can tell you the tendon transfer for elbow extension seems to be stronger than the nerve transfer for elbow extension. You know, there are some people, so let me back up a second. So there is another option for elbow extension that people talk about, which is the posterior deltoid to the triceps. So we did do a prospective study of posterior deltoid to triceps versus biceps to triceps, and our biceps to triceps was more reliable and stronger. So we don't do posterior deltoid anymore, right? We tend to prefer biceps to triceps. But you do have to remember, everybody needs supination for certain tasks, and supination is mainly for eating. So you have to keep supination in one of their hands for eating, because otherwise they can't feed. So if you have a person that are affecting both arms, you'd probably want to be careful about taking away supination on both sides. You can take it away on one side, but not both sides.
Interesting. And so if the tendon transfer is stronger, what do you recommend currently to the patient? Does he decide, considering that one is less aggressive than the other one and the therapy, etc., or what is your strategy with the patient?
No, it's okay. Paco, currently I prefer tendon transfer for that. So I prefer tendon transfer proximal and then nerve transfer distal, right?
Right.
It's interesting because my partner Dan Zlatlo actually went and visited Jamie to see if Jamie was doing something different than we were doing, because we couldn't get the results of Jamie. And we're not. We're doing the same operation. Maybe it's just patient population based. Maybe our patients are a little bit heavier and their arms are heavier. But they can get elbow extension that allows them to, for example, push their sheets off of them. Right? But they can't get enough elbow extension to allow them to transfer or to really push a manual chair up a hill. At least our patients can't.
Okay. And one more question regarding tendon versus nerve transfer. So if you cannot transfer the CRB to the anterior interosseous nerve, would you prefer the brachialis to the anterior interosseous nerve with that long dissection, or the brachialis to the FDP tendon transfer?
So I'm sorry, Paco, say it one more time. I lost the question, sorry.
If you cannot reconstruct the finger flexion with the ECRB to the anterior interosseous nerve,
yes,
would you prefer nerve transfer from the branch of the brachialis to the anterior interosseous nerve, or a tendon transfer from the brachialis to the FDP?
Yeah.
To the FDP.
So it's interesting. So people are transferring the nerve to the brachialis into the anterosseous nerve. We've never done that. I think the brachialis is the workhorse of elbow flexion. In our practice, we don't consider the nerve to the brachialis as an expendable nerve. Back to the principles. So, Justin Brown will harvest the brachialis nerve. We don't harvest the brachialis nerve. It's too important for elbow flexion. I also, in a similar vein, I don't harvest the nerve to the extensor carpi radialis brevis because I think wrist extension is too important. So we just don't take those nerves. I don't think the data supports taking the nerves, and I think the data does support that the brachialis is your primary elbow flexor and your biceps is a secondary elbow flexor along with your brachioradialis.
Dr. Scott, can I have a question from the Facebook Messenger? The question is that the timing of surgeries, especially in those patients, cervical spinal cord injuries, and you have partly answered the question, the difference in surgical approach between the right hand and the left hand. I think you have partly answered this.
Yep. So the first question is with reference to timing. If it is a lower motor neuron injury, so it's at the level of the injury, you have to get to it within the first year, between 6 and 12 months. If the muscle is spastic, then you have all the time in the world because the muscle stays alive from the spasticity. It's so interesting to me to think about the concept of the muscle and the muscle and the reflexes all alive and intact, and that's why they're spastic. That's why there's been such a hope for a cure, because all we need to do is get rid of the damaged spinal cord segment and hook the normal to the undamaged, which is below. But we just have been unable to do it over the last 25 years or 30 years. With reference to one side versus the other, it's a great question. And we spend a lot of time with these patients discussing what they do with each hand because it's distinctly different. And our therapists are fantastic because what they were dominant prior to injury may not be what they're dominant after injury. And you need to consider life's function. So most of the things we do in life are done in pronation. Most of our tabletop activities, most of our cutting food, most of our typing on computer. But supination is extremely important for certain tasks. One we talked about was feeding. Two, believe it or not, is getting soap out of the soap dispenser. Three is carrying something underhanded. Four is wiping your butt, right? And then five would be catching something underhanded, like I said. So those tasks need to be considered left versus right. I like to preserve supination in one arm for feeding. The other arm, I'm okay getting rid of supination or losing supination.
Thank you so much. I think additionally, the indication also, like most of the patients like to change the Foley's catheter by themselves. So also they need some sort of coordination to change the Foley's catheter. I think that's partly your and completely answered the choice of choosing between the right and the left. We have another question from the delegate. Is clonus a significant problem for these patients? And so how does the impact your surgical approach or surgical treatment?
Oh, it's an interesting question. So spasticity and clonus is clearly a problem. But if you think about it, which is kind of hard to grasp, if you take a muscle nerve that's below the level of injury, that's spastic, right? Now it's spastic. Your nerve transfer actually gets rid of the spasticity. If you really think about it, because the nerve that's spastic is now cut and hooked up to a nerve that's normal above the level of injury. So the spasticity or the clonus, whatever you want to call it, will actually go away. But we do have, two physiatrists that manage our spasticity in our spinal cord injury patient population. And that is an important consideration with reference to tendon transfer. You do not want to transfer a spastic muscle. Right, and that goes through for spinal cord injury and also for cerebral palsy. So I don't do any spastic muscle transfers anymore. I'll cut them or I'll lengthen them, but I won't transfer them. You get into all sorts of trouble. In the standard green transfer, which is the flexocarpi ulnaris to the extensor carpi realis brevis, if the flexocarpi ulnaris is spastic in CP, it's a disaster because they end up with a fixed wrist extension posture, and sometimes it forms completely supinated because of the way the flexocarpi ulnaris is rooted. So my advice to people who are learning spastic surgery would be to avoid transferring spastic muscles. It's just a bad idea.
Thank you so much, Dr. Scott. The question following your the topic of cerebral palsy, there's one question there. This attendee thinks that he equates the surgery to cerebral palsy with spastic diplegia or involvement of upper limb. He says that in most of the severe contractures in the wrist, we do a proximal root carpectomy or do a wrist fusion, and then save the tendon for transfer for the vital function. Similarly, would you equate fusing the wrist in those patients and then save the tendon for transferring to, say, for finger flexor or other vital functions?
So in general, in persons with spinal cord injury, we try to avoid fusion because they need grip, obviously, for holding onto an object, but they need opening for letting go of an object and for object acquisition. So it's a little bit different in spinal cord injury. Now, In traumatic brain injury, I think that's where we're talking about spasticity, then we will have a low threshold for either proximal corpectomy or wrist fusion, and then trying to free up a tendon. It's a really interesting idea. It's a little bit of a gamble, right? Because wrist fusion is nice, rock solid, gets them out of spasticity, but then you have to hope your tendon transfer works. So for example, if you decide to fuse the wrist, right, and then you free up a tendon for finger extension, it better work. Because if it doesn't work, they're not going to be happy, because now their fingers are going to be stuck in their palm and they're going to have skin breakdown, et cetera, et cetera. So in spinal cord injury, I can't remember the last time I fused a wrist, but in traumatic brain injury, the answer is absolutely yes.
Thank you so much. Dr. Takehiko, do you have any queries or questions to Scott?
Okay. Thank you for a great talk, Scott. And I'm sorry for the late participation. I have no questions, but it's so important to retrieve a lot you talked. Thank you very much. I have both palsy or PCP patient. Let's keep in contact. Thank you.
You're welcome.
I think we have we addressed all those questions here in the delegates panel. Probably we will have a final conclusion with closing remarks from all those moderators here, and then probably to Dr. Scott. We'll start with Dr. Paco. Paco, your closing remarks, and then.
I think he jumped in the pool.
So sorry. What do I have to do now? Sorry.
Let me take it, Terrence. Let me do the closing remarks.
Yeah,
right?
yeah, please go ahead.
Yeah. So let me tell you in closing, I think for those people who have never taken care of persons with spinal cord injury, and you are interested in a patient population that you will find challenging, both emotionally and physically, but also extremely grateful for the surgery that you provide and the improved function that you provide, you should look at persons with spinal cord injury. I mean, I honestly, it's one of my favorite patient populations. I like getting to know the families and getting to know the kids. They've been through a horrible trauma and they need a lot of support initially, but in the end, they're just like you and me. They want to do what we do. So in terms of very rewarding patient populations, consider taking care of persons with spinal cord injury. They clearly need the help and they need the resources. And it's also fun from a team approach, because it's not just an upper extremity surgeon. There's a physiatrist involved, there's wheelchair involved, there's rec therapy involved. There's all sorts of things involved in taking care of these patients. And they tend to stay in contact with you throughout the years. I have patients I operated on 20 years ago that will drop me an email and say, let me just tell you what's happening in my life. It's that kind of bond, and it's that type of experience that you'll receive from taking care of persons with spinal cord injury. I always question, over the years, of who has received more, them from me or me from them. And I think that's what's so remarkable about this particular distressed patient population that is extremely rewarding. That's what I got.
Thank you, Dr. Scott. I think, ladies and gentlemen, we had this, talk, the nerve reconstruction surgeries or tendon transfers for spinal cord injuries by Dr. Scott Kozin. Today, I think what I have learned and what we have learned is really amazing. We had gone through the ladder of reconstructive surgeries, indications of surgeries, preferably nerve surgeries, and then the tendon surgeries, and the thought of not working surgeries like fusions, especially in spinal cord injuries. Those are the incredible take-home messages from Dr. Scott Kozin. Moreover, he's also very particular about emotional and social support to those injuries patients, because obviously they're like one of us. I mean, that's what the ultimate message we need to take care of that. So friends, I think this is one vital part. I think we should contribute to this special topic of nerve reconstructive surgery, especially in spinal cord surgeries. Lot more things we have learned, and think we really enjoyed having this session with Dr. Scott Kozin. And thank you so much for spending your time here. and also the moderators who have been here despite their busy schedule and also their sort of the relaxment schedule also. So thank you all. Have a good evening and a great day. Thank you so much for joining, and God bless you all. Thank you so much.
Thank you.
Thank you. Thank you so much.
Thank you.
Thank you.
Thank you.
Dr. Jamie could not join us. He said he is somewhere busy, so he just sent me a message. I mean, congratulations and thanks for getting Dr. Scott into this program. I replied him, thank you so much. We missed you today.
Thanks so much. It may take me a while to exit this thing.
Yeah. Thank you, Scott. I'm just going to end the meeting. Thank you so much.
Yeah. Thanks very much. Thanks, Rick.